All right, ready to dive in. Today, we're looking at something pretty big in the fight against tuberculosis, specifically rifampicin-resistant TB.
Yeah, definitely a global health challenge. And a recent study, it was published in the New England Journal of Medicine, just came out on January 30th, 2025, might offer some hope.
That's exactly what we're going to dig into today. We're talking about a potential shift away from those tough, long treatments that can last, well, up to 2 years.
Yeah, sometimes even involving injections. It can be a lot for patients to handle.
Exactly. So this new research is all about shorter treatments, all oral regimens.
Hopefully just as effective.
We've got the study itself and this analysis from MedInsights, which I think is going to help us, especially for healthcare professionals, understand how to apply this research. What do you think?
Yeah, I think the MedInsights analysis is really useful. It breaks down the findings, but also it looks at the strengths and weaknesses of the study, which is, important for putting it into practice.
Okay, so let's jump in. The NTB trial, that's what the study is called, is comparing the standard treatment for rifampicin-resistant TB with 5 new regimens. They're 9 months long and all oral.
They had a good amount of participants, too, over 750 from 7 different countries. And they used this interesting approach to randomization. It's called Bayesian response adaptive randomization.
Now, I'll admit that sounds a bit, well, complicated. Yeah. Can you maybe break that down a little?
Sure. So as the trial went on, the researchers could see which treatments were doing well. And then they could adjust how likely it was for new patients to get those treatments. It's a more dynamic way to run a trial.
So it's like fine-tuning it as you go.
Yeah,
That's
exactly.
really fascinating. Okay, but let's get to the results. Did these shorter treatments actually measure up?
They did. 3 out of those 5 new regimen, they were non-inferior to the standard treatment.
Non-inferior meaning.
Just as effective, statistically speaking, at achieving what we call favorable outcomes.
Meaning, beating the TB, right? Giving the patient a real chance at a healthy life.
Exactly. And when you look at the numbers, 3 of those regimens, BLMZ, BCLL-FXC, and BDLL-FXC, they had favorable outcomes in over 85% of the participants.
Wow, that's impressive,
Yeah.
especially compared to that longer standard treatment, which had a favorable outcome rate of 80.7%.
Right. It suggests that these shorter regimens could really be a good alternative for patients with rifampicin-resistant TB.
So for healthcare professionals listening, what do you think is the biggest takeaway here? What stands out to you?
I think the potential impact on patient care is huge. Imagine being able to give your patients a treatment that's shorter, easier to take, and just as effective. It could really improve their quality of life.
It's not just about treating the disease, it's about, minimizing the disruption to their lives.
Absolutely. Shorter treatment means maybe they can get back to work sooner, spend less on healthcare, and have fewer side effects from those injections.
There was actually this story in the study, one of the participants talked about how much hope these shorter treatments gave them.
Oh, yeah.
They were, thinking about going back to work, providing for their family sooner. It's pretty powerful.
Yeah, those personal stories really bring it home.
We have to talk about limitations, right? Every study has them. The NTB trial, it was open label.
Meaning everyone knew which treatment they were getting.
Yeah, so could that have skewed the results?
It's possible, but they did try to minimize bias. The lab staff, for example, didn't know who was getting what, and the findings were consistent across different groups, which helps.
Okay, so something to keep in mind, but doesn't necessarily invalidate the whole thing. What about the MedInsights analysis? Anything in there that healthcare professionals should pay attention to?
They really emphasized being careful about which patients get these new regimens. While they're promising, you really need to consider each patient's individual situation, medical history, and potential risk factors.
So not a one-size-fits-all approach.
Definitely not. It's about having more options and knowing how to use them wisely.
Right, so more personalized treatment plans.
Well, exactly. Now, they did point out that there were some small imbalances between the groups in the study.
Like maybe one group had slightly more older people or something.
Yeah, things like that. It's not a huge deal, but could potentially affect the results. They also talk about the possibility of false negatives.
Because of the sample size.
Right. There might be other effective regimens out there that just didn't show up as statistically significant in this study.
Makes sense?
And then finally, they cautioned about generalizing the results too much.
Because the trial, even though it had people from different countries, it doesn't necessarily mean these findings will apply everywhere.
Exactly. Different healthcare systems, different TB prevalence rates, those things matter.
So more research is needed, but it's definitely exciting.
For sure. Welcome back. We're digging deeper into this research on shorter treatments for rifampicin-resistant TB. So let's kind of zoom out a bit. Think about what this could mean globally.
Right? Rifampicin-resistant TB, it's not just the problem in one place, it's a global health issue. How could these shorter treatments change things worldwide?
Well, one of the biggest things is treatment adherence, sticking with the treatment plan. Right now, treatment can take up to 2 years. That's a long time for anyone.
Yeah, and especially in places where access to healthcare isn't so easy.
Exactly. And if someone doesn't finish their treatment, the TB might not be fully gone. It could even become more drug resistant.
It's a scary thought.
But these shorter regimens, imagine being able to tell your patients, hey, you can treat your TB in 9 months, all with pills. It just seems more doable, right?
Definitely. It makes it more likely that people will actually finish their treatment, which helps everyone in the long run.
Exactly. It's better for individual patients and for global public health. Now, let's talk a little bit about the medications themselves. We know they're using a combination of different drugs, but how do they actually work against TB?
Yeah, I'm curious about that. We've talked about the big picture, but the details are fascinating too.
Absolutely. So one of the drugs is bedaquiline. It's a newer drug, and it targets how TB bacteria get their energy. Basically, it starves them,
So it cuts off their fuel supply.
pretty much. And then there's delaminid. It also messes with their energy production, but in a different way. It stops them from making mycolic acids, which are part of their cell wall.
So it weakens their defenses.
Exactly. And both bedaquiline and delaminid, they work in ways that older drugs don't. That makes it harder for the bacteria to become resistant.
Really important in the fight against drug-resistant TB. Now, linezolid, that's another drug in some of these regimens. I've heard it can have some side effects.
Yeah, that's true. Linezolid stops bacteria from making the proteins they need, but it can also affect protein synthesis in human cells, which can cause side effects.
Like what kinds of side effects?
It depends. Some people might get nausea or stomach problems, but there can be more serious ones too, like nerve damage or problems with bone marrow.
That sounds a little scary. Is it safe to use then?
It is, but you have to monitor patients closely, watch for any signs of trouble. In the NTB trial, they actually lowered the dose of linezolid after 16 weeks to try and minimize the risks.
Okay, that makes sense. What about clofazimine? I read that it was originally used for something else.
Yeah, it was used to treat leprosy, but they found it also works against TB. We don't know exactly how it works, but it seems to disrupt the bacteria's cell membrane and metabolism.
So it's kind of a multi-pronged attack.
Yeah, you could say that. And then that's really important when you're dealing with drug-resistant TB. Hit it from different angles to make it harder for it to fight back. They also use pyrazinamide in some of the regimens. That's an older drug that's been used for TB for a long time.
Still effective.
It is. It's well tolerated and works against many strains of TB. Sometimes the classics are still useful.
Okay, so we've talked about the drugs. Now, you mentioned earlier that there are some ethical considerations with these new treatments. What are some of those?
Well, it's great to have effective treatments, but everyone who needs them should be able to get them, and that's not always easy.
I imagine access to diagnostics is a big part of that.
Absolutely. You can't treat someone if you don't know they have rifampin-resistant TB. And in many parts of the world, especially in low-resource settings, getting a quick and reliable diagnosis can be tough.
So even if we have these amazing new treatments, if people can't get diagnosed, it's not going to help them.
Exactly. So as these shorter treatments become more common, we have to make sure people can get diagnosed. Otherwise, we could actually make things less fair.
That's a really good point. It's not just about the science, it's about making sure it reaches the people who need it most.
Couldn't agree more. Now, let's go back to that randomization method for a second. That Bayesian response adaptive randomization, it's still kind of blowing my mind.
Yeah, me too.
It's pretty clever. As the trial went on, they gathered data on which treatments were working best. And then the algorithm they were using automatically adjusted how likely it was that new patients would be assigned to those better performing treatments.
So the trial was basically learning as it went along.
Exactly. It helped them figure out the most effective treatments faster and also meant that fewer people got treatments that weren't working as well.
It seems like a really good approach, especially for a serious disease like TB. But the meta-insights analysis, they mentioned that this kind of trial design isn't without its challenges.
Right. Some people argue that it can be more complicated to analyze the results and that there could be some bias. But I think the benefits, especially in terms of speed and getting answers quickly, outweigh those concerns, especially for diseases like TB where we need new treatments urgently.
It makes me think this approach could be really useful for studying rare diseases, where it's hard to get a lot of participants for a trial.
Yeah, that's a great point. By adjusting the randomization as you go, you can learn more from a smaller group of people. It could really speed up research in those areas.
Okay, so we've talked about the global implications, the ethical considerations, even the way the trial was designed. But what about the long-term effects of these shorter treatments? I'm thinking about potential side effects that might not show up right away.
That's a crucial question. The NTB trial, they mainly looked at outcomes at 73 weeks. That tells us a lot about how well the treatments work and if they're safe in the short term. But we need to follow people for longer to see if there are any delayed side effects.
Especially since some of these drugs, like bedaquiline and dielmanum, they haven't been around that long.
Right, we need more data to really understand their long-term safety, especially in different populations. Ongoing monitoring and research are key. We also need to think about the possibility of relapse. The trial did track people for 104 weeks, but that's still not that long in the grand scheme of things. We need to see if these shorter treatments are as good as the longer ones at preventing TB from coming back.
It's important to see how they work in different groups of people, too. Like people living with HIV, who are more likely to get TB. We need more research to make sure these treatments are safe and effective for everyone who could benefit.
I completely agree. Now, there's one more thing we need to talk about, and it's the cost. New drugs, especially ones that work this well, they're usually expensive.
Yeah, that's a big question, isn't it?
hmm
We're excited about these breakthroughs, but can people afford them? Especially in places with limited resources.
It's a complicated issue. The good news is that the NTB trial was partly funded by Unitaid. They're an international organization that helps make new healthcare tools more affordable. So that's a good sign.
It is, but even with their help, we still need to make sure pharmaceutical companies make these drugs affordable. We need to look at different ways to manufacture them, maybe even generic versions, so that everyone can access them.
It's going to take a group effort. Governments, healthcare providers, pharmaceutical companies, everyone needs to work together to find solutions. And we can't forget about advocacy. We need to keep talking about drug-resistant TB, keep pushing for policies that prioritize access to affordable treatment.
It's about making sure that these scientific discoveries actually improve people's lives. Now, one last thing I've been thinking about is the impact of this research on future TB treatments. Could these findings actually lead to even more innovation in the field?
I think so, absolutely. The NTB trial showed that shorter, all-oral treatments for drug-resistant TB are possible. That could really encourage researchers to explore new and creative ways to treat TB.
It's like opening up a whole new world of possibilities.
Exactly. We might see more research on drugs that work in completely new ways, making it even harder for resistance to develop. Maybe even new vaccines or treatments that help the body fight TB better.
It's exciting to think about the impact this could have on the future of TB research. Now, before we move on, there's one more point I want to bring up. The NTB trial, they focused on a specific type of drug-resistant TB, the kind that's still susceptible to fluoroquinolones. What about cases that are resistant to both rifampin and fluoroquinolones?
That's a really important point. Those cases, they're often called extensively drug-resistant TB or XDR-TB, and they're much harder to treat. While these new regimens are a big step forward, they don't solve everything.
So while we have a lot to celebrate, the fight isn't over.
Definitely not. We need to keep investing in research and working together globally to find treatments for XDR-TB and other forms of highly resistant TB. It's a reminder that these breakthroughs are important, but they're just one part of a bigger picture.
And the fight against TB, it's a marathon, not a sprint.
Absolutely. We need to keep going, keep innovating, and keep working together to reach the finish line.
All right, welcome back to the last part of our deep dive on these new, shorter treatments for rifampin-resistant TB. We've really gotten into the science and the impact, even some of the ethical stuff. Now, I'm kind of thinking about the future. What does all this mean for the fight against TB, in the long run?
It's a good question. These findings, they're definitely promising, but it's important to remember they're just one part of the solution. We need a bigger, more well-rounded approach to really tackle TB.
When you say well-rounded, what do you mean?
It's about understanding that TB isn't just a medical problem, right? It's connected to all these other things, social, economic, environmental factors, things like poverty, malnutrition, overcrowding, limited healthcare access. Those all make it easier for TB to spread.
So even with great treatments, if we don't address those issues, it's going to be tough to make real progress.
Exactly. It's about creating a healthier society for everyone. That's where sustainable TB control starts.
It really highlights how healthcare is linked to so many other things. Okay, let's talk about future research. What areas could make a big difference? I'm thinking things like new diagnostic tools, vaccines, maybe even preventative treatments.
Oh, yeah, those are all critical areas. For diagnostics, we need tests that are faster, more sensitive, cheaper, and easier to use, especially in places with limited resources.
Can you imagine a world where you could diagnose TB in minutes, right there in a small clinic?
It would be a game changer. Early diagnosis means faster treatment, which helps stop the spread and improves outcomes for patients. And then there's vaccines. We have the BCG vaccine, but it's not that effective in adults.
So we need something better.
Absolutely. A new vaccine that really protects against all types of TB, including drug-resistant strains, that would be incredible. It could potentially save so many lives.
Definitely worth working towards. Now, preventative treatments, I've heard about those, giving people at high risk of TB antibiotics ahead of time.
Yeah, that's called prophylactic treatment.
Hmm.
It's especially important for people with HIV or those who have been exposed to someone with active TB. It's about being proactive.
Okay, one last question. Do you think we'll ever see a world without TB?
That's the dream, right? I'm cautiously optimistic. We've made a lot of progress, and with more research and global cooperation, I think it's possible. But it'll take time and effort.
It's a long road, but it seems like we're moving in the right direction.
I think so. But it requires all of us to do our part: healthcare workers, researchers, policymakers, everyone.
And that includes our listener, right? We can all do something, stay informed, advocate for more funding, support organizations doing this work.
Exactly. Every bit counts.
It's about understanding that we're all connected. We have a responsibility to protect each other from this disease. Well, I think that brings us to the end of our deep dive.
We covered a lot of ground. Hopefully, we've given you some things to think about and maybe spark some hope for a future without TD.
Thanks for joining us on this journey.
And remember, keep learning, keep asking questions, and keep working towards a healthier world.
Until next time, stay curious.